Welcome and thank you for joining us. Tonight's event, In the Know, is a live expansion of the Here for the Girls annual health guide, a guide to caring for yourself that is published in conjunction with our calendar, which recognizes and shares the journeys of many young women diagnosed with breast cancer. My name is Melissa Weaver, and I am going to be our moderator this evening. We welcome speakers from Riverside Health System, Virginia Oncology Associates, Myriad Genetics, and VCU Massey Cancer Center to discuss vital, clinically relevant breast health and breast cancer information. Information presented in tonight's discussion is for educational purposes only. For answers to specific healthcare questions and concerns, you should consult your healthcare provider and your healthcare team. So it is my great honor to bring forth this amazing group of individuals. So thank you all for joining us this evening. What I'm going to do first is give you a little bit of information about these amazing speakers that we have with us this evening. And then we will move into the question and answer period. And so this is not the question and answer that will happen at the end. This is a question and answer that I will be leading a discussion from, but we will have a question and answer period at the end. So you can put your questions in and then we will address them in the end. So we are going to start with Dr. Vernita Lynn Williams from Riverside Health System. And Dr. Williams will discuss why it's important to know what is normal for your breast. Dr. Williams graduated from the Medical College of Virginia in Richmond. She completed her residency at Lancaster Regional Memorial Center in Pennsylvania and received a fellowship from the University of Tennessee. She is board certified by the American Board of Family Medicine and specializes in family medicine and obstetrics. Dr. Williams is a Riverside Foundation board member. A very big welcome to Dr. Williams. Next, we have Dr. Nina Balanchavadze. Dr. Balanchavadze received her medical degree from the Tbilisi State Medical University in Tbilisi in Georgia. She completed her residency in internal medicine at Yale New Haven Medical Center at Yale University in New Haven, Connecticut, and her subspecialty training in hematology oncology at Henry Ford Cancer Institute in Detroit, Michigan. Her clinical interests include breast cancer, neuroendocrine malignancies, and classical hematology. Dr. Balanchavadze is passionate and caring for patients with cancer and providing personalized state-of-the-art compassionate care for all of her patients. We give a great welcome to Dr. Balanchavadze. Thank you so much for joining us this evening. Next, we have Sarah Pass from Myriad Genetics. Sarah is a certified genetic counselor who has been working at Myriad as a regional medical specialist for 4 years. She received her bachelor's degree in biology from Furman University and her master's degree in human genetics and genetic counseling from Emory University of South Carolina. Since joining Myriad, Sarah's focus has been on genetic education surrounding hereditary cancer and precision tumor testing. A very big welcome to Sarah this evening. Thank you for joining us. We also have Dr. Candace McGuire. Dr. Candace McGuire is a breast surgical oncologist and professor of surgery at Virginia Commonwealth University in Richmond, Virginia. She also serves as the director of breast surgery at VCU, as well as the surgical leader of the comprehensive breast cancer clinic at the VCU Massey Cancer Center. She conducts research in addition to providing patient care, leading clinical trials to improve patient outcomes. Her research focuses on minimizing breast cancer intervention, targeted surgical and medical therapies for breast cancer, and decreasing disparities in breast cancer detection, treatment, and survivorship. A very big welcome to Dr. McGuire. I'm going to pause for a minute because that was just some fantastic information that we are giving you. So welcome to everyone. Again, just as a disclaimer, I just wanted to remind you that the information that we are about to discuss is for educational purposes only. So just as a reminder. So what we are going to do now is we're going to move to these topics of conversation. Know that what we did is we separated it into these different topics. So therefore, we could get a better understanding and a deeper understanding of the latest in cancer news and cancer information. And these amazing individuals have agreed to join us and bring their expertise to the table. So we are going to go ahead and get started. So our first set of questions is going to be for Dr. Williams. So Dr. Williams, in the guide for caring for yourself, you detail how to better know your breast, including signs and symptoms that may alert you to changes you should share with your healthcare provider. Could you further discuss the importance of breast self-awareness?
Yes, thank you, Melissa. I'm excited because this term, breast self-awareness, might seem like a new one. Often you may have heard about breast self-exams or clinical breast exams, but the term breast self-awareness might be a little new. And so when you look at why, I believe as the medical community, we want to make it simpler and easier for women to understand what we're talking about. A lot of times we use medical jargon and we kind of realize we weren't doctors born, we are doctors by profession. So the term awareness is something that people are more familiar with. Awareness, recognizing facts, recognizing perceptions. And so breast self-awareness makes more sense. And it means one being aware of their breast. And when we say that, what are we looking for? We're looking for changes. And I wanted to stress, normal for one person is not normal for the other person. So right off the bat, your normal is different than my normal, is different than Sue's normal, is really different than Jim's normal. We're not going to be talking about men today, but realizing breast normalcy, normal breast is individualized. So breast self-awareness is a term that I want people to be really comfortable with saying, with describing, with talking to their friends, and ultimately talking to a healthcare professional. So what are we looking for in terms of normal? There may be differences in sizes that people are born with that grow as they mature in life. There may be lumps, and we say lumps and bumps a lot, I do, that may be normal or not. There may be changes in skin, dimpling, nipple changes, changes in colors, discharges from the nipple, things that hurt or don't hurt throughout the month or different days. So breast self-awareness means that that woman is aware of changes, and changes don't necessarily mean cancer. So I want people not to be afraid or fearful or anxious of a change. When a change happens, that means we go back and serially look at our breast, feel our breast, examine our breast to see if that change is something that's new or it's something that's persistent. And then when you get a change, talking to a healthcare professional is the best way to relieve anxiety. It's the best way to be reassured that, hey, this is my norm, or this may not be normal, and we may need to consider some other testing. Lastly, we know that self-breast awareness is the first way of early detection, which then means early treatment. And all of us are here tonight to help you as well as us understand that early detection absolutely means early treatment. So I'd like to leave those points with you, that normal is individualized. And another point, breasts do change with time. So it's absolutely okay to realize that change is good. And if there are changes that are noted, talking to your healthcare professional with the whole goal of having early detection, thus early treatment.
Absolutely. Thank you so much, Dr. Williams. And two things that I really think are, I mean, everything you said was so key, but two of the things that really stood out to me was this idea of self-awareness. You know, we talk a lot about self-awareness in many aspects of our lives, and I think that that also applies to our physical health, obviously. And so I think bringing that terminology in is fantastic. The other thing that I really like that you talked about was this idea of what is someone's normal, and what one, right, yeah, and meeting each patient where they are in their normal.
Right.
So I think that's fantastic. Thank you so much for that information. So could you provide, you talked a little bit also about the three components of breast cancer and early detection. Could you discuss a little bit more about those pieces, the annual screening, the mammograms, and the clinical breast exams, how they all three of those work together?
Absolutely. You know, the first place that we look is to ourselves. So this self breast us or breast self awareness is something that you can do within yourself. If you need a partner or someone to help you, we realize as physicians, as healthcare professionals, we're not there first. So after something is noted or you're not sure, you contact your healthcare provider. And then we look at your risks and we look at different things that may put one at an increased risk or not for breast cancer. And given those factors, you may lead onward to other testing. In terms of screening for breast cancer, and screening tests are done principally to get a host of persons together, then to try to detect disease. So we look at the self breast exam or self breast or breast awareness beginning around 25, 21, 25. And generally, you'll find those are the times that we're looking maybe for other cancers, such as cervical cancer. So, doing this monthly breast awareness or self breast awareness exam amongst yourself then is one component of trying to detect cancer. Um, After 40, in the average risk woman, we then talk about screening mammograms, which is a radiographic test. And so that can be absolutely essential in detecting something that's abnormal, which may lead to further diagnostic tools. You then have a clinical breast exam, which some physicians still perform in the office, which again is just another piece of information that helps us get closer to detecting cancer or not. And so, again, I think when we use that tripod approach, the breast self-awareness, the clinical breast exam, the screening mammogram after 40, or looking at one's history and family history, because it may be necessary to have a screening mammogram prior to 40, depending on your risk factors. So often we use that three-tiered approach. First, self-breast awareness. Also, that comes with the person knowing their history. So please ask questions of your aunts, your uncles, and I would say even of your grandfathers and your uncles, because male breast cancer can be a risk factor in terms of the female having breast cancer. So when a person gathers information about their body through the awareness approach and then awareness of their history, then they can move forward to screening tools after 40 or earlier, depending on those risk factors, and then a clinical breast exam. And as we'll hear about tonight, there are so many other wonderful testing, including genetic screening, that we can do in that whole formula.
Absolutely. Thank you so much. That is such um, a thorough discussion related to those components and how they work together. So thank you so much for that. So
Welcome.
as we talk about accessing pieces, so do you have any recommendations for accessing educational materials or screening tools, and treatment options? What would be your recommendation on accessing those pieces?
Well, first I tell people all the time, please don't just do a Google search. Often that gets us into trouble. And I find a lot of the times as a healthcare professional, I'm having to erase or redirect persons away from information that is not helpful. Often, I would say go to your healthcare provider. The American Cancer Society has lots of wonderful information and actually videos of persons who have done different to or experienced different things. And they started some of them with breast self-awareness. I find too that Riverside has information and actually a wonderful printout that shares with you when people should become aware of their breast in terms of ages, if you want to look at numbers, and then screening mammograms. Personally, I like mayoclinic.org, which is a wonderful site as well for information. So I would say make wherever you go to for information is credible, is current. And I would just speak with a person after you read materials and look at videos, and that would be your healthcare provider.
Absolutely. Thank you so much. And those are great recommendations for accessing all of these different components. And then the final question that we have before we move to the next section is this idea of, these educational pieces or these screening tools or treatment options. you know, do you see any barriers that you think it would be important for individuals to know about ahead of time, so therefore they can best plan? Or and do you have any support options that you would recommend for that?
Mhm. Well, I think barriers primarily are not wanting to know, being anxious, assuming that it doesn't involve you, assuming that it's not important. I know that there was a bad word in the word assume that I learned early on. If one assumes, I'm not going to repeat it. However, we shouldn't assume. So assuming that it won't happen to you, to me, is the wrong approach. I say knowledge is power. And so one of the barriers to me is that individual who says, I don't want to know, and they put their hands in their ear and they kind of try to block it out. We can't afford to do that anymore. We all want to live, but we want to have good quality of life. So I would say a barrier sometimes is the person. Secondly, clearly, the financial approach may cause some people to say, well, I don't want to seek attention. I would say that there are lots of different resources out today, in this age that we live in which services may be free. And so I would ask them again to seek the health professional offices, your organization, Riverside, other organizations, because genetic screening may be free or at lower cost. Gathering information is often free. It just depends on the type of information. Also, who you hang with in your neighborhood or your group or your girls or your boy group, they may not want to talk about it. And I find if you have an individual, you do self breast awareness and you notice something, please don't hide it. The Bible would say under a bushel. I want you to realize and take it seriously and go with the fact that something is there, something is different. I may not have support from my group, but I need to get information for my body. So I think the major barriers that I've seen, and we can go around the table, have been those self barriers that we put up. And also this thought that I'm not important or it won't happen to me, and the financial ones, which we can definitely overcome so that everyone lives longer and healthier and has healthy breast, which is what we're aiming to do.
Thank you so much, Dr. Williams. And I'm going to borrow one of your statements. Knowledge is power. And I think that's something to take with us for your message this evening. Thank you very much for that information. So as we move from the idea of identification and we move from that place of self-awareness, as Dr. Williams so beautifully put, we're going to now move into this idea of treatment. And so to discuss treatment with us is Dr. Balan Shavade. And so we welcome her and thank you so much. So the first question is, as many of us know, breast cancer treatment, although essential, comes with potential side effects. Knowing that every individual's journey is different, could you identify key potential side effects related to surgery, chemo, radiation, and immunotherapy.
Hi, everyone. Thank you so much for having me. It is truly my pleasure. Um, Talking about side effects of treatment, could just I can go on and on forever. So as a medical oncologist, we have about, among many tools, about, 3 different types of treatment in our toolbox. We have chemotherapy that everybody fears, and we have immunotherapy, and we have also targeted therapy depending on what type of cancer individual has. So each of those treatments have different side effects. If I generally talk about each, cytotoxic chemotherapy or standard chemotherapy, it affects any cell that's rapidly dividing in the body, and that's how it really acts on and attacks the cancer cells. Therefore, we expect side effects really in all the entire body, every cell that's rapidly dividing. So these are the hair follicles. So we see hair loss, depending on the chemotherapy, but we do see a lot of hair loss in most common chemotherapies used in breast cancer. We see oftentimes, because of the effect on the bone marrow, where all the important red cells, white blood cells, and platelets are made, there is effect on that, and therefore there is increased risk of infection. There is decrease in blood components, which may require one to receive blood transfusions. We also see effect on the gastrointestinal tract, going all from the mouth all the way down to the bottom, and can manifest as nausea. We see reflux or heartburn. Some women experience diarrhea, some experience constipation. We see skin changes, oftentimes dryness of the skin, different types of skin rashes, and we see often nerve pain, or what we call neuropathy, or decreased sensation in the fingers or the toes. So these are kind of the main side effects of the chemotherapy part. In regards to immunotherapy, as immunotherapy acts on to activate the immune system to kind of, in a way, attack the cancer cells and kind of break down those checkpoints that the body has built, it can affect normal functioning cells as well. So oftentimes we see, we may see skin changes such as rashes. We can see effect on lung, such what we call pneumonitis, which is just inflammation of the lungs. We see its effect on the liver, and we can also see immunotherapy affect our endocrine system, oftentimes thyroid, or affect the hormones that help us deal with stress. So this can be mild, or it can be even life-threatening. So, everybody wants to receive whatever is the latest and the greatest type of treatment, but, nothing comes without side effects. And then if we talk about targeted treatments, and, if we talk about anti-HER2 treatment for those cancers that express HER2 protein, oftentimes we may see side effects such as diarrhea, because basically all the other cells that express HER2 or have those receptors can get activated. And then, one of the more feared side effects is the cardiac toxicity that can be seen. In regards to surgery, we have Dr. McGuire here, but I oftentimes see, women having diminished sensation, breast sensation, or pain, or feeling there is constant pulling and oftentimes anxiety of not knowing, is there something that's growing? Is this scar tissue, or is it something that's just growing and something new developing? And then for radiation, nowadays our techniques have changed so much and have become so much more and one individualized and higher technology. We don't see that many burns anymore. They can happen, increased sensitivity. So these are kind of like, and this can be, everybody is individual, as Dr. Williams said. So we can have this side effect mild or can be severe as life-threatening. So these are important to consider when choosing treatment options for our women.
Thank you so much. And you're right. We could have a whole day or definitely a session on this discussion. And for those of us, our listeners out there, you know, that can be scary to hear about all of these side effects. But as Dr. Williams said, knowledge is power. So I think it's important for us to have these conversations, even though they can be hard conversations to have. So thank you so much for that. Are there any side effects that you think would be key side effects related to tamoxifen or aromatase inhibitor treatment following that initial treatment?
Yeah, that's a great question, because we are finding detecting more and more cancers at earlier stages now because of more awareness and screening. Therefore, a lot of our women, majority of the cancers are hormonally driven or hormone positive. So therefore, oftentimes after surgery, even if we don't use, whether we use chemotherapy or not, oftentimes we have to use anti-estrogen or hormone therapy, and that can be aromatase inhibitors. And I'm sure our listeners have heard of anastrozole or letrozole or exemestane. And then we use tamoxifen, which is one of the selective estrogen modulators. These side effects are different. Mostly are driven by the fact that these drugs do what they're supposed to do. They deplete estrogen where they're supposed to deplete estrogen. So most of the side effects are related to that. So often, most commonly bothersome side effects that I encounter are joint pains, joint and muscle pains with aromatase inhibitors, which can be debilitating. We see hot flashes that women experience. And then other side effects that are commonly described: bloating, mood swings can happen. And then one of the side effects that we worry about, especially in women that are postmenopausal, is the loss of bone density or bone, because menopause itself is a risk factor for bone fractures. And then you add on additional medications that further block any estrogen that's available. It may lead to premature bone loss as well as fractures. And so that's for aromatase inhibitors. Now, tamoxifen acts differently, so at different sites. Therefore, women don't experience as much joint pains, but hot flashes may occur, and then bloating, weight gain can be a side effect as well. But there are two side effects that I'd like to point out for tamoxifen, which are increased risk of blood clots. And fortunately, that percentage is not as high, and oftentimes the risk of the clots is a lot lower than the benefit of the cancer recurrence. But we like our women be aware of this potential side effects. And the second one is, and seen mostly in postmenopausal women, is endometrial cancer. And again, fortunately, number one, the risk is low itself. And oftentimes we get an early warning signs if that were to happen, and it manifests itself as what we call a dysfunctional bleeding, or we warn our women that if you notice any bleeding, it's never normal to have bleeding in a postmenopausal setting, to bring that to our attention. And then we make sure that our women are under the care of our gynecology partners. So they're getting yearly pelvic exams, and it's to prevent this from happening or detect early. And luckily, most of those cancers are detected early. So these are, again, I can go on and on, but these are the main side effects that we see and are worried about.
Thank you so much. Thank you for providing us with information related to side effects in all of these areas. So that kind of leads us to the next question, and that is strategies. So for those individuals that are receiving treatment, and I know again that we could spend a considerable amount of time, so I can already see a round two forum for us, but just to kind of touch on general strategies that patients can use and can utilize during this time.
Great question. So I number one, again, we talk about individualism, and I tell women it's individualized. Every woman is different. So it does not mean you're going to get every side effect written in the FDA label for the drug. So it's individualized. And number two, I've discussed anticipation and prevention. So prevention is very important, not only for detection, but in preventing side effects. So as an example, for hot flashes. So I talk to women about trying to anticipate it. So, avoid spicy food, avoid alcohol, avoid caffeine intake. Also, if you feel like a hot flash is coming on, drink cold water, and sometimes that helps subside it. At night, sleeping, use natural cotton coverings, so things that you can do to kind of prevent this. There are pharmacologic methods as well, so you can speak to your oncologist about some of the medications that can help prevent the hot flashes. Number two, for bone, muscle, joint pains, to prevent and to help is movement. So movement is the best medicine we have. So I encourage my women to exercise or even walk, 30 minutes a day, 5 times a week. So aerobic exercise. I've had many women who started high intensity training in the postmenopausal, post-breast cancer diagnosis, and they've actually helped build bone, so movement is important. A proper diet is so important. So this, I don't want to use Mediterranean diet, but, plant-based, low sugar. So I'm all about what you put in your body and what you put in your mouth is so important. And then, other things, we do as physicians to prevent bone loss as well. We have medications, and then we have different, medicines in the toolbox, but most importantly, bring it to the attention of your doctor as soon as possible. So some of these side effects can be mitigated. And then if these side effects continue, oh my gosh, if one doesn't work and gives you side effects, we can change it. And studies have shown that actually changing from one aromatase inhibitor to another can lessen those side effects. And then if that doesn't work, try tamoxifen. And then if that's because people now live longer with breast cancer after breast cancer diagnosis. So I want everybody to have a fulfilling and good quality of life, not crippling. So there are ways to mitigate those side effects.
Thank you so much. Like you said, we could go on, and I really, really appreciate all of the knowledge that you brought to the table. And we take it back again to what Dr. Williams said, and now you have said, is that everyone is different and everyone's journey is different. And that seems to be a theme, which I think is going to continue with our next two speakers as well. So thank you very much. So we are going to move from treatment. We talked about diagnosing. We then went into treatment, and now we are at the genetic portion of this evening, which is an extremely fascinating portion and very important. So we welcome Sarah Pass for that piece. So Sarah, could you provide us with a brief overview regarding the role of genetic testing in relation to breast cancer? I know it's changed over the years quite a bit.
Yeah, I feel like this is changing constantly. I feel like even if you asked me this question last year, it'd be a vastly different answer of what I give now. But just to go back to basics, there are a lot of different genetic conditions and testings. The genetic testing we care about in the cancer world are testing for genes that are supposed to be protecting us from cancer. That's their entire job. But we know some people are born with changes, or you might hear the word mutations, that make it so those genes aren't protecting us from cancer. So we see cancer develop at younger ages. We see multiple cancers in the same people or related cancers within a family. And so knowing that information can give us a lot of power. And again, that knowledge is power. And so we want to know that in order to kind of threefold. One, it lets us know what the risk of the patient is at. There are multiple genes that can increase the risk for breast cancer, but they don't just increase the risk for breast cancer. They often increase the risk for other cancers. And so for the patient, we're already treating one cancer. We don't want to treat another. So we want to know what can we do to prevent or detect early for that other cancer. We also know that having one of these genes that increases the risk for breast cancer, one of those common second primary cancers is another breast cancer. So they might choose a different surgery or to go through different preventative measures in order to make the right choice for them. And we also now know that some of these hereditary syndromes also have treatments based specifically in those mutations, those changes, those genes. And so if we know a patient has one of these changes, we might change the treatment that they have after chemotherapy. And so these are all really important components of that patient's treatment. It's also really important for family. So these are hereditary syndromes that someone is born with, and that also means they're passed from one generation to the next. That means that it's not just the patient in front of us, it's their family too. And in the world of genetics, we definitely want to treat the patient in front of us and those with breast cancer, but we also want to detect these patients that have that increased risk before they ever have cancer. We want to try to be preventative. We want to put you into those screenings earlier. We don't want to wait till 40. We want you to go in earlier. We want them more frequently. We want to take those preventative measures to help these patients get treated early, detected early, where it's much easier to treat these cancers. That's really our goal in genetics in the breast cancer space. And I could probably talk for another hour on it, but I'm going to stop there.
Well, I think we could probably have an hour discussion on so many of these topics. So thank you so much for sharing that information with us. And I'm obviously not a genetic counselor, but every time you turn around, there's something new, that you can read about related to genetics and breast cancer. So thank you for bringing that to the table. So could you discuss a little bit about the potential barriers in accessing genetic testing? I know not everyone knows about genetic testing. And, especially as it relates to insurance or prohibitive cost and potential support through Myriad to address those barriers.
Yeah, absolutely. So there are a couple of big barriers that I feel like come with genetic testing. One is just knowing what it is. I feel like a lot of patients, you hear about it in the news, but don't always know, do you qualify, do you not? So always ask the question to your provider, do I qualify? Is this something that I should be talking about? There's always going to be someone around. There's a lot of telegenetic counseling services out there for people to talk to. Ask the questions, get the knowledge. If you don't meet testing criteria, we love to be able to say that, but we also don't want to miss the patients that absolutely do meet that criteria and want that testing. Thankfully, the barrier of cost is decreasing significantly. If you asked me this 2 years ago, I would have a very different answer. Thankfully, the cost of testing is decreasing significantly. Insurance is covering this a lot better now. For unaffected women who haven't had breast cancer, there's the USPSTF, United States Preventative Service Task Force, and they recognize testing for BRCA1 and 2, the two most common hereditary breast cancer syndromes. that's a preventative service. So that's usually covered at no cost to the patient. Can't guarantee anything because insurance likes to do its own thing, but for the most part, that's covered. For our patients with breast cancer, there is an FDA approved test for BRCA1 and 2, again, that same 2 genes, where we can get that covered because it's under a treatment idea. It is dependent on the patient in front of us to get an answer for them. It's not, well, it could be helpful down the road. Insurance sees that as, oh, this is something I need to do right now. This is definitely something that's going to help this patient. So coverage is much better now for all of those. And then last choice, if insurance really isn't going to pay for it, most labs now have a out-of-pocket cost, a direct pay option for patients that is not fantastic, but at least more manageable than the $2,000 it used to be. It's now about $250 to $300, depending on the lab. And then also at Myriad specifically, we have a financial assistance program that is meant to help patients who might have a huge out-of-pocket or deductible that they haven't met yet. We don't want cost to be that barrier for the patient because this information is so vital for their treatment or for their family or both.
Absolutely. Thank you so much. And that is really important information. And I'm really grateful to hear that that cost is declining and is becoming more available to everyone. So speaking of genes, this leads me to the final question. And that is, could you address those variants that are listed as are of unknown significance, and how patients should respond should they receive this type of result? Because that could be quite distressing to get this and not know, what do I do with this information?
Yeah, I think VUS is, or variant of uncertain significance, that VUS has to be one of the most frustrating results to get sometimes, because it essentially just means we don't know. And nobody likes to get a result of we don't know. So what I will say is, when I got this result in clinic, the recommendation would be, we're going to follow you based on family history and your personal history, and treat this as essentially a negative until we know more, because we don't want to put someone through a surgery or preventative measure that isn't actually going to benefit them. It might take months or years for that variant to be reclassified. So I would always recommend, if you've got a VUS on your genetic testing, keep in contact with the doctor who did that genetic testing. They're the ones that are going to receive that reclassification when it comes, for the most part. And so there have unfortunately been times where we've reclassified something and we can't find the patient. And that's frustrating for us, I'm sure, because we can't get the right answer to the right person. It's also frustrating for the patient too, because they're not getting the answer that they need, and they can kind of finally have that answer. I will say, in a reassuring point of all of this, while variants of uncertain significance are frustrating to get, the vast majority of them, about 90% of them, turn out to be benign or negative. They're just normal changes that make us different from each other. So that's always reassuring. But again, that 10% that might become positive down the road, meaning that's increasing that risk for change, please keep in contact with your doctor so that we can find you, get you that information, and get you down the right path.
Thank you so much. That is just amazing information to share. So thank you very much. I really, really appreciate it. So we're going to wrap up this evening's panel discussion with Dr. McGuire. And Dr. McGuire is from Massey Cancer Center. And we'll start our conversation this evening, Dr. McGuire, with the article, in the article, Novel Dye Saves Lymph Nodes in Women with Breast Cancer. And in that article, you discuss how an innovative approach can help preserve lymph nodes and prevent lymphedema in women with breast cancer. Can you elaborate on this approach a little more and why it's important?
Absolutely. I think it's something that's very exciting. And this is definitely one of the known sort of side effects or unintended effects of surgery for breast cancer. So most women who have surgery for breast cancer will require some form of what we call axillary staging, where we check the lymph nodes in the axilla or the armpit of the same side where your breast cancer is to make sure it hasn't spread. But that's not true for every woman. In fact, there are some recommendations that women above the age of 70 with smaller tumors don't need that. And there definitely, we know that women who have this thing called DCIS, or ductal carcinoma in situ, which is a stage 0 breast cancer, their tumor cells are stuck inside their ducts. They can't get to the lymph nodes. And so we really don't need to do axillary surgery in these women. The problem is that because this is stuck within the ducts, when it grows, it goes up and down the ducts, and it can often get to a big portion of the breast requiring a mastectomy. And so when that happens, the big question is going in as a surgeon, what if I find invasive cancer and I didn't check the lymph nodes? So a lot of people will check the lymph nodes as a preventative measure just in case. But really only about 11% of women actually will go from DCIS to invasive cancer when you do their mastectomy. And so we have the great privilege of using a dye called MagTrace dye. And that dye can be injected into the breast at the time of a mastectomy for DCIS or any other cancer. The great thing about this dye as compared to traditional dyes is it actually sits around the lymph nodes for about 4 weeks. So we have the time to do the mastectomy, get our pathology back, and only take the patients back for lymph node assessment who actually have invasive breast cancer. So we save about 85 to 90% of women their lymph nodes who have to have a mastectomy for DCIS, which it sounds like a very narrow group, but about 60,000 women are diagnosed in the US with DCIS in the yearly. And of those, at least 30 to 40% of them will have a mastectomy. So it's a big number of women that we can save their lymph nodes and reduce their risk of lymphedema to nothing.
Absolutely. Yes. I mean, this is just amazing information to have. And like we discussed earlier, such an innovative approach. So thank you so much for sharing this. And I know that our listeners are going to be very interested in that information. So thank you very much. So the next question is, and before I ask the next question, we're getting close to the time where we can do a question and answer period. So just a reminder, if you do have your questions, please send them in so that way we can go ahead and have those ready for our amazing panel. So could you share how studies using the MagTrace and other breast cancer research conducted at VCU connects to the mission of VCU's Department of Health, Behavior, and Policy?
Yeah, so that was a mouthful, but I appreciate the question. The thing about research is that it's only good for those upon whom we have data. And one of the big problems we've had traditionally is that certain groups have been excluded from research trials, whether it's by design of the trial or by willingness of certain groups to actually participate in clinical trials. So for many, many years, especially when we look at drug delivery and drug development, we saw drugs developed for based upon research of men only that were then given to women. And many times we actually found that those drugs were harmful for women. The same thing can be said for children. For years we thought children were just small adults. And so now what we're seeing is those disparities being addressed. But what we still have to work on are underserved populations, our Hispanic and African American populations who have been traditionally really underrepresented in clinical research. And so when we combine our public policy and our outreach groups with our research groups, we find that we're able to not only serve our population better, but that we actually get that research out to the women who need it. And so that we are studying the real US and not just the US that we see sometimes published in papers. And so it's a great opportunity for us to be able to break down some of those barriers.
Thank you so much, Dr. McGuire. And you actually answered the last question as you were doing that. So yay, I appreciate that.
Yeah.
But so what I'll do is throw one additional question at you that I think will be very easy to answer. I don't want to like throw it at you without you knowing it's coming. But could you let our individuals know that if they are interested in learning more about the novel dye, the new protocol, how they would go about finding out more information about that?
Absolutely. So, I mean, you can go to the website of the company that develops it. But really, if you think that you have a DCIS and you're going to require mastectomy and you want to know more about it, I think it's something you need to ask the team that you're working with. And if they're not using it, then we are always happy to have a second opinion at Massey. And so really what you call 1-800-Massey. And we will get you in touch with somebody who can answer those questions. And so, I think that, the one thing I probably didn't really explain very well was what lymphedema is. So I just kind of glossed over that, but for women in the audience who are not familiar, and hopefully, you're not familiar because you don't have it, is lymphedema is swelling of a part of your body that's happened because you've had impaired what we call lymph flow. So not only do we have blood vessels in our bodies, but we have lymph vessels. And when the lymph vessels get blocked for some reason, then everything back behind it will start to swell up. And so this can be very mild. It can be very infrequent. It can be very frequent. And it can be very severe, and you never know who you're going to be ahead of time. There are certain things that predispose women to lymphedema, like lymph node surgery, that will make them more likely to have it. So actually being overweight, having a sedentary lifestyle, having an infection of that affected limb, or having an infection around the time of your surgery. What's interesting is the things that we always hear about, the no blood pressures, the no IVs, a little bit of hogwash. So if you've had a minor axillary surgery, like a sentinel lymph node biopsy, please do not let somebody put an IV in your foot. That arm is just fine to use as long as you've not had any problems with lymphedema. So sorry to segue there, but I just wanted to get that out because women, I think, are suffering, with, one of their arms being a pincushion and then going to feet, which is just horrible when they've got a fully usable arm.
So thank you, Dr. McGuire. So let me just clarify. I want to make sure I heard you correctly. So that other arm is something that can be used?
Yes. So if you've had, especially if you've just had a sentinel lymph node biopsy, which is just a check of 1 or 2 lymph nodes, the risk of lymphedema is in the single digits. And if you haven't experienced it, after your surgery, then the likelihood of you developing it because somebody put an IV in your arm or took a blood pressure off your arm is next to 0. So, but the things that increase the risk are the things that nobody wants to talk about. Being overweight, not using your arms frequently for things like exercise, weightlifting actually reduces your risk of lymphedema. So, these are the myth busters that I always like to put out.
Wow. Thank you so much. I've just learned so much this evening, and I know our viewers out there have also learned so much. So we have completed our portion of the evening where we're discussing with our experts in these areas. So now what I'd like to do is go to our chat and see what question that we might have or questions that we might have. And if you have not had a chance to load in your questions, please do so. And so what we're going to do, and anyone can chime in at this point for questions. So I welcome you with your feedback. So the question is, can early detection and treatment decrease the chance of metastatic breast cancer? So that's the main question. And the individual that posted that did give some background information as it relates to their diagnosis, but I think because you won't be able to answer an individual, clinical question. I think just sticking to that main question of, can early detection and treatment decrease the chance of metastatic breast cancer?
I'll just start because I know that the specialist, I definitely want to hear you all's perspective. That's why we kind of start with the person and the self-breast, awareness first, because early detection means early treatment, which hopefully then means no metastatic movement or less chances of metastatic movement. And we are not God, so we can't say that early detection, early treatment means no metastatic delivery. We can't say that. And we know there's so many factors, genetic, yes, but other things that we don't know about that interplay in all of this. So like, Dr. McGuire was saying, exercise, not drinking alcohol, not smoking cigarettes, dietary changes, as Dr. Nina was saying, and then knowing your genetic status. I mean, all of that is essential to decrease the chance of metastatic spread. unfortunately, we have heard of those people that had early detection, early treatment, and then further on in their life's journey, there was some return of breast cancer or metastatic involvement. So, that's a hard question to answer. But what our point is and our perspective is early detection is early treatment. And then the rest, I would say, is left up to God or whoever you believe in. But we do try to detect early so that we can treat early and hopefully prevent metastatic disease.
Thank you so much. Would anyone else like to chime in on that question?
I'll be happy to chime in as well as a medical oncologist here. So unfortunately, we find that younger women are often diagnosed with more aggressive types of cancer. And then they're also diagnosed at a later stages of cancer for various reasons. But in general, cancer is more aggressive in young women. Secondly, at the time of diagnosis and treatment does matter, because at a higher stage, the risk of recurrence is higher. For example, we go with the tumor size, so we call T, and the metastases. So if T1, if the recurrence rate is 10%, then T2, or if the size is more than 2 centimeters, that brings that up to 15 or 20%. And then your lymph nodes, depending how many lymph nodes you have affected, there's a percent with that too. And then if you have triple negative disease or HER2 positive disease, that adds an additional percentage as well. So it depends, if you have lower stage and you do maximum, your risk of recurrence is hypothetically lower. But having said that, I would still say that younger women have more aggressive disease. So that's why we are so aggressive and try everything we do to prevent this from happening.
Thank you so much. Would anyone else like to speak on that? Yes, Dr. McGuire.
Yeah, so building off of that, I think that the first thing that came to mind when I saw that question was just looking at the graph. If you were to go to the American Cancer Society, if you look at the graph of women passing away from breast cancer, and you see the graph of mammography for early detection, as mammography increased in the 1980s and the 1990s, breast cancer mortality decreased. And while some of that was due to better treatment, most of it was due to early detection. And so the one thing that I would urge young women to do is actually start talking to their physicians about when they should start screening as early as age 25, because if they are high risk due to a family history or genetic mutation, they're eligible for screenings, not just mammograms either, but MRIs as well, where you might get that early detection even at that very young age, where you do tend to have a more aggressive cancer.
I really appreciate all this information, and I know we're running out of time. We have another question, but before we do, I would actually wouldn't mind asking one question just to connect to that question. Can one of you or all of you speak to the information out there about hormone receptive positive cancer, and the information that it doesn't necessarily decrease, your reoccurrence rate doesn't necessarily decrease over time? Is that accurate because of the hormone piece, or does it decrease over time, the possibility of reoccurrence?
I think I'll take that question. So, we do have data out there that show that because in general, hormone positive cancer is a lower grade cancer. So the risk of recurrence is there even at 20 years, believe it or not. While in triple negative cancers, most of the recurrences do happen earlier. But unfortunately, with hormone positive cancers, late occurrences can happen, and it can be both local as well as metastatic. When that does happen, then we wonder, is this a new cancer? Because if a person was at risk of getting one cancer, is this the same cancer or not the same cancer? So that's why it's so important to be in a center where you have a dedicated breast medical oncologist, you have a breast medical, breast surgeon, you have a tumor board or multidisciplinary discussion, because these are very fine details that need to be combed through. So truly multidisciplinary care is the way to go in such situations.
No, thank you so much. And I know several of our members have talked about this topic, which is why I brought that question to the table. I really appreciate you responding to that. So I know that we are out of time, actually. So we do have so many questions coming in. Do you all mind if I pick a couple more? Are you okay with staying on for a few more? Okay, so this one is for Sarah specifically. Sarah, it says, if we had genetic testing many years ago, is there updated information based on that profile? Which I think what the person is saying is, and then they said, or would I need a new test? I think they're asking, will someone update them automatically, or do they need to go and get a new test with the new genetic components?
Yeah, so I think I'm going to answer this in a couple parts because it could go a couple of different ways, and I want to make sure I answer what they might be asking. So if we're talking about a result you had in the past, thankfully our genes don't change. The result you had before will stay the result you have now. If you have a variant of uncertain significance, it depends on the lab that did your testing. I know Myriad, we reach out specifically when we have a reclassification to get that information to you. Some labs, you actually have to probe them to get them to reclassify, but you don't need a new sample for that process. It's just talking to your provider to get that answer from the lab. If you're looking at getting updated testing because there are new genes you want to have analyzed, that does need a new sample and would require you to go back in and get those genes analyzed. And I would say that genetic testing has changed a ton over the years. The genes we know now are not the same genes we knew even, I would say, 5 years ago. So it really depends on when your initial testing was done. But it's always worth talking to your physician, or if you have a genetic counselor, talking to them to see, is it worth doing an update test with new genes?
Thank you so much, Sarah. And we do value your time so much and the time you've given. So I'm going to stop us at 7:40 and we're going to get through as many questions as we can. So I'm not going to talk anymore. I'm just going to read questions. So the next question is, can you talk about when a breast MRI may be needed? Would it be in addition to or instead of a mammogram? So this sounds like it's about self-awareness, the self-awareness piece, Dr. Williams.
It really depends on your risk factors. And if you are a woman of average risk or higher than average risk, and that really depends on if you have first degree relatives that have had breast cancer. As I mentioned before, if you yourself has had breast cancer or some other type of cancer, smokers, various other risk factors. So it really depends on which category the woman is in. Often using myself as an example, my sister had triple negative breast cancer diagnosed at 42, and I'm older than she was. And so I did have that discussion about screening MRI, doing a Q6 months with a regular or 3D mammogram and or something called BSGI. And so I had the discussion with a radiologist regarding the need for MRI screening. So I would say it depends on one's risk factors. And it does need to be a discussion either with the radiologist, with an oncologist, with your healthcare professional, because you may be one that needs to be screened with an MRI as opposed to your three-dimensional average or normal screening mammography.
Thank you so much. Would anyone else like to comment on that piece before we move to the next question?
I would just say very briefly, yes, you have to have a lifetime risk of breast cancer greater than 20% to be eligible for MRI. It should be done with mammogram because mammogram can show some things that MRI cannot. And if your radiologist or your regular physicians cannot give you an answer as to what your risk is, then there are risk models out there and risk calculators that you can try to access yourself, or you can work through a high-risk program or an oncologist.
And then I'll just chime in too, if you're a carryover high risk genes that are proven to cause breast cancer, as well if you've received prior chest radiation for whatever reason, like women who are lymphoma survivors, for example, or have had other malignancies require chest radiation, would be another indication for us as well for screening purposes. And then we also use it in the surveillance purposes, which I don't know if the time allows for that.
Thank you so much. Okay, so our next question is kind of a specific question, so I'm going to try to make it a little more general. One of our members was told by their OBGYN that they did not need to come in annually anymore. But they were then also told that it's important to have an exam when taking tamoxifen. So if someone could just speak to, do you recommend that individuals continue to see their OBGYN, especially if they're taking tamoxifen?
Yes, short answer is yes.
Okay, thank you so
Annual
much.
pelvic exam, thank you.
Thank you. So the next one is there a reason why a doctor would take lymph nodes out even though they use dye the day of surgery? So this is a surgical question.
Yeah, so I think that really boils down to what exactly you're trying to do with this dye and the lymph nodes. And so what we're talking about is a sentinel lymph node biopsy. And so what the dyes allow you to do is they allow you to inject a dye into the breast that then traces to the first couple of lymph nodes that drain your breast. Because prior to that technology, we had to take out all the lymph nodes to assess them. So the dye getting up to those lymph nodes does not tell you whether they have cancer in them. They just tell you which ones drain your breast first and which ones are the most likely suspects. So those lymph nodes that light up with the dyes then have to be removed so a pathologist can evaluate them. So even with the use of the dye, the lymph nodes must be removed to be evaluated by a pathologist. And so that's really how sentinel node biopsy works. And the dye is nothing magical, except it just maps out your drainage pattern.
Excellent. Thank you so much. So the next question, or the last one I have on here, unless we have any others that have come in, and that is perfect timing, is this individual were recently told that if the cancer was HER2 positive only, it is very unlikely for it to return after 5 years. So I think they're basically saying they only had a HER2 positive diagnosis. Is this consistent with your clinical experience? So I guess not to speak to this individual's case, but in general, do we have a thought on reoccurrence if someone is not hormone positive, but only HER2 positive?
Yes, in general, that is, I would say, close to a correct statement because of the more aggressive nature of the HER2 disease. You know, we expect recurrence earlier compared to the hormone, but we truly don't know. But most of the HER2 positive cancers, they do like to recur early.
All right. Well, okay. That seems to be it. Those were great questions for those of you that are listening. I hope I responded to everyone's question. And so I'd like to kind of close this out really quickly. And I'm kind of going off script for just a moment because I cannot thank you enough. I don't know if you really know how important this evening was for our listeners to have these amazing minds in one room answering questions and providing this just really crucial information. So I cannot thank you enough for taking your time this evening out of your busy schedules and joining us. So thank you to all of you for joining us this evening. And be sure to check out the calendar Here for the Girls for upcoming events, including more ways to join virtually. And thank you to everyone that joined us this evening out in the community. And we hope that everyone stays safe and well. And a big thank you to our panel again. Thank you so much.
Thank you.
Yeah, thank you.
Thank
very
you.
much.